Imagine just walking into a doctor's office feeling perfectly healthy. Like you have no blurred vision, no weakness in your legs, no mysterious tingling in your hands or anything.
Right, you're just there for something totally routine.
Exactly. Maybe you had, I don't know, a mild concussion from a minor car fender bender, or perhaps a stubborn migraine. And that prompted your doctor to order a routine MRI of your brain just to be safe.
Just crossing their T's and dotting their I's.
Yeah. So you were sitting on the exam table, scrolling through your phone, expecting to be sent home with some ibuprofen. But instead, the neurologist walks in, puts your brain scan up on the monitor, points to a few tiny white spots on the screen and says, "You have multiple sclerosis."
Which is just a massive world-altering bombshell.
It really is. And, 10 years ago, this scenario was virtually impossible. But today, it is an actual clinical reality. We are witnessing what is arguably the most monumental seismic paradigm shift in the history of neuroimmunology.
Oh, absolutely. I mean, the ground beneath the feet of every practicing neurologist is completely shifting right now. For decades, the diagnosis of multiple sclerosis was a strictly clinical exercise.
Right.
We operated on this fundamental, almost archaic principle of waiting. We waited for a patient to suffer, and then we literally waited for them to suffer again before we felt confident enough to name the disease and actually begin treatment.
Which sounds so counterintuitive when you say it out loud.
It really does. But what we are looking at today is a fundamental untethering of the diagnosis from that clinical suffering. We are moving toward a highly precise, invisible pathobiological definition.
And that is exactly what we are unpacking for you today on this deep dive. Whether you are a clinician trying to stay ahead of the curve, a researcher fascinated by neurobiology, or just someone who, wants to understand how cutting-edge medicine is redefining what it actually means to be sick, we are taking you straight to the frontier.
Yeah, we are diving deep into the 2024 revisions to the McDonald criteria.
Right. Relying specifically on the latest comprehensive Continuum issue on MS and related disorders, which is published by the American Academy of Neurology. We are going to explore how we measure microscopic differences in the retina, how we count broken antibody parts in spinal fluid, and how we use magnetic resonance to find these tiny iron deposits in the brain.
It's basically science fiction turning into clinical practice.
It really is. But before we get to the futuristic tools, we kind of have to understand the problem they are solving. Why did we historically force patients to play this agonizing game of wait and see?
Well, to understand the traditional approach, we really have to look at how MS behaves biologically. Historically, diagnosing MS was tied to a very specific phrase, which was dissemination in space and time.
Space and time. Okay, let's break down the biology of that.
So MS is an autoimmune disease.
Yeah.
It's where the body's immune system mistakenly attacks its own central nervous system. So we're talking about the brain, the spinal cord, and the optic nerves. And specifically, it attacks the myelin sheath, which is that fatty protective insulation wrapped around the axons or the nerve fibers. When that insulation is stripped away, a process we call demyelination, the electrical signals traveling down the nerve basically short circuit.
So I always think of it like a frayed electrical cord on a lamp. Like if the rubber casing is chewed off by a dog or something, the wires are exposed, the lamp might flicker, it might spark, or it might just stop working altogether depending on how the cord is bent.
That's a perfect analogy. And in a human being, that flicker translates to a sudden, very real deficit. It could be sudden blindness in one eye or overwhelming vertigo or, a leg that suddenly just won't bear any weight.
And that's what we call the clinical attack.
Exactly. That's the clinical attack. Now, because other diseases can also cause a single attack, neurologists needed proof that this was a chronic, ongoing, widespread process.
Right. They couldn't just guess based on one event.
No, exactly. So they needed proof of dissemination in space, meaning the immune system was attacking multiple different geographic locations within the central nervous system.
Like having a lesion in the optic nerve, plus maybe another one down in the spinal cord.
Precisely.
Yeah.
And they also needed proof of dissemination in time, meaning the attacks were happening on different dates. This was the only way to prove this wasn't just one isolated freak inflammatory event that the patient was going to recover from and never deal with again.
Which means, practically speaking, the doctor had to look a patient in the eye and say, "You just had a terrifying episode of temporary paralysis. It might be MS-GO, but to prove the time element, I have to send you home and literally wait for you to have another terrifying neurological event."
Yeah.
I mean, that sounds archaic. It sounds almost cruel to the patient, honestly.
Oh, it was incredibly frustrating for everyone involved, doctors and patients alike. But it was born out of a necessity to avoid misdiagnosis, with the relatively crude tools we had available at the time.
Right.
However, Dr. Lyle K. Jones Jr., who is the editor-in-chief of this Continuum issue, he highlights in his preface, which he aptly titles Neurology's Action Potential, exactly why this old model is utterly unacceptable today. And it comes down to a simple phrase.
Yeah.
In the brain and spinal cord, time is tissue.
Time is tissue. Let's dig into that phrase because it is the anchor for literally everything we're going to discuss today.
Yeah, so when an inflammatory attack occurs and that myelin is stripped away, the underlying axon, the actual wire transmitting the signal, is left entirely exposed and vulnerable.
Like the bare wire in the lamp cord.
Right. And in the early stages of the disease, the body can sometimes attempt to repair the myelin. We call that remyelination. But it's imperfect.
Like putting cheap electrical tape over the fray.
Exactly. It holds for a bit, but it's not the original casing. And with every subsequent attack, the inflammation is so severe that the axon itself can be severed and die.
Oh, wow.
Yeah. And unlike a cut on your skin, or even a broken bone that knits back together, an axon in the central nervous system basically cannot regenerate. Once it is gone forever. The resulting neurologic deficit becomes permanent.
So every month spent waiting for that second clinical attack to prove dissemination in time is a month where irreversible brain damage is silently accumulating.
Precisely. Which is why the ultimate goal has shifted entirely toward early intervention. Prevention of damage is fundamentally a stronger partner in neurological care than attempting to rehabilitate a severed neural pathway after the injury has already occurred.
Because once the bridge is burned, it's burned.
Right. The new criteria are designed to catch the disease biologically long before it ravages the nervous system clinically.
Wait, hold on. I need to challenge this whole concept because I can hear you, our listeners, raising an eyebrow at this. If we are diagnosing a life-altering disease based on silent molecular markers or protein ratios or microscopic iron deposits before a patient even feels consistently sick, aren't we just treating a lab result instead of a human being?
It's a very fair question.
I mean, if a patient feels totally fine, why should they care what their spinal fluid protein index is? Doesn't this risk turning a physician into like a data entry clerk who just reads a spreadsheet and prescribes a harsh immunosuppressant?
That is the exact fear Dr. Jones addresses, and he terms it the fear of reductionism. It's a very valid anxiety that as neurology becomes more molecular, it basically becomes less neurological, less human.
Yeah.
But if we look at the history of medicine, we see a totally different pattern. When the MRI machine was first introduced and widely adopted, there were these loud predictions that we wouldn't need neurologists anymore.
Oh, right, because the machine would do it all.
Exactly. The fear was the machine would simply print out a picture of the brain, a technician would point to the white spot, and the diagnosis would be made automatically.
The machine would basically do all the thinking for the doctor.
But the reality proved to be the exact opposite. The advent of MRI exponentially increased the need for expert clinical contextualization. It's just because the machine reveals a massive amount of data, right? A whole universe of white spots, many of which are completely benign. You need a highly trained human being to look at that scan, correlate it with the patient's lived reality, their medical history, their specific subtle symptoms, and actually recognize the microscopic red flags.
Right, because context is everything.
Yes. These novel biomarkers we are unpacking today, they demand more clinical expertise, not less. They are incredibly sensitive tools, but they are utterly reliant on the clinician to interpret them correctly and safely.
So we aren't firing the doctor. We are basically handing the doctor a high-powered electron microscope instead of a magnifying glass.
That is the perfect way to frame it. And to understand how this molecular pathobiological shift works in practice, we need to look at the concrete changes in the 2024 McDonald criteria.
Okay, let's get into the criteria.
We have a new map of where to look, we have new ways to measure time without waiting, and we have new ways to see the active fire in the brain. And I think the most logical place to start is with the map itself.
The map, right. The brand new anatomical territory that has been officially annexed into the diagnostic criteria.
Exactly.
The optic nerve. We're talking about a whole new dimension of space. Because for decades, to prove that dissemination in space, the criteria relied on 4 traditional anatomical locations in the central nervous system.
Right, and those 4 classic locations were heavily weighted toward the brain and spinal cord. First, you had the periventricular area.
And the ventricles are those fluid-filled spaces right in the center of the brain, right?
Yes, and the white matter immediately surrounding them is a classic breeding ground for MS lesions. Second, you have the cortical or juxtacortical regions.
Which is the outer part.
Yeah, in or right next to the cerebral cortex, that outer folded gray matter of the brain. Third, the infratentorial region, which sits lower down at the back of the skull and includes the brainstem and the cerebellum.
The parts controlling vital functions and coordination.
Exactly. And finally, the fourth location was the spinal cord itself. Under the old rules, if a patient had lesions in 2 or more of those 4 distinct areas, they met the criteria for dissemination in space.
But the 2024 revisions officially introduce a 5th location, the optic nerve. Now, on a purely intuitive level, this feels incredibly obvious, right?
Oh, completely.
Because optic neuritis, which is this severe inflammation of the optic nerve that causes rapid vision loss, color desaturation, and this deep aching pain when you move your eye. That's one of the most common presenting symptoms for people with MS. It's often the very first terrifying thing that sends a young adult to the emergency room. So why wasn't it included before?
It wasn't included primarily because of the historical difficulty in objectively measuring the damage to it compared to the brain. The optic nerve is really unique. It's actually a direct extension of the central nervous system, not a peripheral nerve.
Oh, it's
Yeah, it's wrapped in the exact same myelin produced by oligodendrocytes that you find in the brain, which makes it a prime target for the MS immune attack. But the old criteria were strict. A patient couldn't just sit in the exam room and say, my vision was blurry last year.
because self-reported clinical history is too subjective.
Exactly. We needed objective, measurable proof of a lesion in space.
And now we finally have the technology to gather that objective proof. The criteria outline specific, highly technical ways to confirm an optic nerve lesion. One way is through a dedicated orbital MRI. But this isn't your standard brain scan, is it?
No, not at all. It requires a specialized MRI protocol focused specifically on the orbits, the eye sockets, and it uses fat suppression techniques.
Why suppress the fat?
Because the optic nerve is surrounded by orbital fat, which appears very bright on a standard MRI. That brightness easily hides the bright signal of an inflammatory lesion. So by using a fat suppressed sequence, the radiologist artificially darkens the surrounding tissue so the actual inflamed nerve stands out.
That makes total sense.
And the 2024 criteria are very specific about what they need to see. An MS lesion typically affects less than 50% of the optic nerve's total length. Like less than half. Right. And it usually sits primarily in the intracanalicular and intraorbital segments, basically the parts of the nerve right behind the eye and passing through the bony canal into the skull.
So that's the imaging approach. But the criteria also allow for electrophysiological proof using visual evoked potentials, or VEPs. This sounds like something straight out of a sci-fi movie. How do you physically measure the speed of sight?
It's a fascinating physiological test. A technician places small recording electrodes directly on the patient's scalp.
Like an EEG.
Very similar, yes.
It's there.
They place them specifically over the occipital lobe at the very back of the head, which is where the brain processes vision. Then the patient is asked to stare at a screen, displaying a black and white alternating checkerboard pattern.
Okay.
The exact moment that visual stimulus hits the retina, an electrical signal fires down the optic nerve through the optic radiations in the brain and hits the occipital lobe.
And because electricity travels at a known speed, the machine is basically running a stopwatch.
It is precisely a stopwatch. In a totally healthy nervous system, that electrical signal reaches the occipital lobe in about 100 milliseconds.
Super fast.
Very fast. But if the optic nerve has been demyelinated by an MS attack, the insulation is gone. The signal leaks out, it degrades, and it travels much slower. Yep. So the VEP will record a delayed latency. Maybe it takes 120 or 130 milliseconds for the signal to arrive.
Wow.
Yeah, and that delay is objective numerical proof that a demyelinating lesion exists on that specific optic nerve pathway, fulfilling the requirement for a lesion in space.
But the coolest addition here, the technology that truly feels like we are living in the future, is the inclusion of optical coherence tomography, or OCT. I love explaining OCT to people because I basically think of it as an optical biopsy. We are looking directly at central nervous system tissue without ever picking up a scalpel.
Optical biopsy is a brilliant way to conceptualize it. Because the retina is contiguous with the optic nerve, it is essentially central nervous system tissue laid bare at the back of the eye.
Just sitting right there.
Right there. And OCT doesn't use radiation or magnets. It uses near-infrared light waves. It shines these light waves into the eye, and by measuring how the light echoes or bounces back off the different microscopic layers of the retina, it constructs a highly detailed, high-resolution cross-sectional image. We are talking about resolutions on the scale of micrometers.
Let's contextualize a micrometer for a second, because a single human hair is about 70 to 100 micrometers thick, right? And a red blood cell is about 8 micrometers across. So we are measuring living tissue at a cellular level. What exactly is the machine looking for to prove MS?
It is measuring specific layers of nerve fibers that funnel into the optic nerve. Specifically, clinicians are looking at the peripapillary retinal nerve fiber layer, the RNFL, and the macular ganglion cell interplexiform layer, which we call the GCIPL.
Okay, RNFL and GCIPL.
Right. And when an optic nerve lesion occurs, the nerve fibers die off, and these layers in the retina actually thin out. They atrophy.
It's like a river drying up because the dam upstream was blocked.
That is the perfect mechanical analogy. The cell bodies in the retina literally wither because their axons in the optic nerve have been severed. And to confirm this objectively, the 2024 criteria provide very strict mathematical cutoffs.
They don't just guess.
No, absolutely not. You can't just look at one eye. You have to compare the patient's eyes to each other to establish a baseline. You are looking for an inter-eye difference, a thinning in the affected eye compared to the healthy eye. For the RNFL, the criteria require an inter-eye difference of 6 micrometers or greater.
6 micrometers, a distance smaller than a single red blood cell. That is the threshold for diagnosing a lesion that could lead to a chronic, lifelong disease. It's wild.
It really is. Or, if they use the GCIPL layer, they are looking for an inter-eye difference of just 4 micrometers or greater. If you have those objective measurements calculated automatically by the OCT software, you have officially confirmed involvement of the optic nerve.
You tick the box for that 5th anatomical location.
Exactly. And this is expected to radically increase the diagnostic sensitivity for MS. We are going to catch people who had an incredibly mild, perhaps entirely asymptomatic optic nerve lesion years ago that they just brushed off as a tired eye, but which left a permanent 5 micrometer dent in their retinal thickness.
Okay, so if we zoom out, adding the optic nerve brilliantly expands our map of where MS can hide. We have a wider net to catch dissemination in space, but let's look at a very common clinical scenario.
Sure.
What if a patient comes in, they have severe optic neuritis, we run the OCT and find that 6 micrometer difference, but we scan their brain and their spinal cord and there is nothing else. They only have lesions in one anatomical location.
Right, clinically isolated syndrome.
Exactly. We haven't proved dissemination in space. Under the old rules, we'd have to send them home and wait for a second attack to prove dissemination in time. How do we prove time without actually waiting for more brain damage to occur?
This is the crux of the diagnostic dilemma, and it leads us directly into how the 2024 criteria have fundamentally rewritten the rules for dissemination in time, or DIT. They have achieved this by officially elevating a newly validated, highly automated fluid biomarker in the cerebrospinal fluid.
The cerebrospinal fluid, the CSF. Getting this fluid requires a lumbar puncture, commonly known as a spinal tap, where a needle is carefully inserted into the lower back to draw out the clear fluid that bathes the brain and spinal cord. Historically, what were we looking for in that fluid to substitute for time?
For many years, the gold standard biomarker in the CSF was the presence of CSF-restricted oligoclonal bands, or OCBs.
Let's break down exactly what oligoclonal bands are, because the mechanism here is so vital to understanding the new update. What is an oligoclonal band?
So to understand the band, you have to understand the B cell. B cells are a type of white blood cell, and they act as the immune system's weapons factories.
Weapons factories, I like that.
Yeah, their entire job is to manufacture and secrete antibodies, those Y-shaped proteins that tag and neutralize invaders, like viruses or bacteria.
Right.
When the central nervous system is healthy, there shouldn't be a massive army of B cells inside the cerebrospinal fluid.
Right.
It's supposed to be a tightly regulated, quiet environment protected by the blood-brain barrier.
But in MS, the blood-brain barrier is breached. The B cells get inside, set up camp, and start churning out antibodies against the patient's own tissue.
Yes, and they produce specific clones of antibodies in massive quantities.
Yeah.
To detect this, lab technicians perform a process called gel electrophoresis.
Which sounds incredibly complicated.
It's a bit tedious. They take the patient's spinal fluid, place it onto a specialized gelatin-like matrix, and apply a strong electrical current across the gel. Because proteins carry a natural electrical charge, the current physically pulls the proteins through the gel. Smaller, lighter proteins move quickly toward the other end. Larger, heavier proteins get bogged down in the matrix and move slowly.
Oh, it's like a microscopic foot race through a swamp. The light runners finish first, the heavy runners get stuck near the starting line.
Exactly. When the race is over, the proteins have separated based on their size and charge. The technicians that apply a stain, and the clusters of identical antibodies show up as distinct dark lines or bands on the gel.
Okay.
If you see multiple bands in the spinal fluid that are not present in the patient's blood serum, those are CSF-restricted oligoclonal bands. It proves conclusively that there is an active, ongoing chronic immune response localized entirely inside the central nervous system.
So, finding those bands essentially told the doctor, this immune fire has been burning for a while and it's isolated to the brain. It was an accepted proxy for time. If you had the bands, you didn't have to wait for a second clinical attack. You had proven DIT.
Correct.
So if OCBs are so great and tell us all that, why are we changing the criteria?
Because the physical process of evaluating OCBs is notoriously fraught with logistical and human error. It is incredibly time-consuming and labor-intensive, but the biggest problem is that it is fundamentally rater-dependent.
Ah, subjective.
Highly subjective.
Yeah.
You're relying on a human technician looking at a stained, sometimes blurry piece of gel under a light to subjectively decide. Is that a faint band? Is it an artifact of the staining process? Are there two bands or just one thick one?
It's essentially an art form disguised as a lab test. If two different technicians look at the same gel, they might give two entirely different answers.
Which is unacceptable when a patient's lifelong diagnosis hangs in the balance.
Yeah, completely.
So the 2024 criteria introduce a revolutionary alternative, the kappa-free light chain index, or the KFLC index. This new biomarker is now considered entirely interchangeable with OCBs. You can use one or the other.
Let's dive deep into the biology of kappa-free light chains. We're still looking at those B-cell antibody factories inside the spinal fluid, right?
We are. Picture that Y-shaped antibody again. It is constructed from 4 protein chains, 2 identical heavy chains that form the trunk and the inner arms of the Y, and 2 identical light chains that form the outer tips of the arms.
Right, heavy and light.
The B-cell factory manufactures these parts separately and then assembles them. But when the immune system goes into a hyperactive inflammatory overdrive like it does in MS, the assembly line gets sloppy. The factory churns out way too many light chains. They don't all get attached to the heavy chains.
So wait, these surplus parts just get swept off the factory floor and basically float freely into the cerebrospinal fluid?
Yes, those are the free light chains. And there are 2 types of light chains, kappa and lambda. For complex immunological reasons, the B cells driving the pathology in multiple sclerosis overwhelmingly overproduce the kappa type.
Okay.
So if we can measure the concentration of kappa-free light chains in the CSF, we have a direct, highly accurate measure of how aggressively the B cells are operating inside the brain.
And the beauty of this new test is how we measure it, right? We aren't making technicians squint at blurry lines on a gel anymore.
Not at all. The measurement is entirely automated. We use techniques called nephelometry or turbidimetry, where a machine passes a beam of light through the fluid sample and precisely measures how much the light scatters when it hits the suspended proteins.
Wow, so it takes the human eye completely out of the equation.
Exactly. It calculates an exact mathematical index by comparing the ratio of free light chains and albumin in the CSF to the ratio in the blood serum. It's observer independent, it's fast, it requires less fluid, and it's highly reproducible from lab to lab.
And the 2024 criteria have established a very specific, hard mathematical cutoff for this, haven't they?
Yes, the diagnostic threshold is set at an index of 6.1. If the automated machine spits out a number of 6.1 or higher, the test is positive. You have mathematically proven ongoing intrathecal inflammation, and you have officially fulfilled the criteria for dissemination in time.
That's incredible.
And the data backing this up is staggering. The sources note that a positive KFLC index boasts an 87% or greater concordance with OCBs. They are practically biological twins in terms of what they tell us.
This sounds flawless. It's faster, it's cheaper, it's automated, and it completely removes human error. So let me ask the obvious question. If KFLC is so superior, why didn't the 2024 committee just abolish OCBs entirely? Why keep the old messy gel test around at all?
Because biology is never a perfectly closed system, and automated machines lack clinical context. The KFLC index is a ratio, remember, comparing the brain fluid to the blood serum. If something is altering the proteins in the blood serum, the math equation breaks down entirely.
What would alter the proteins in the blood?
The most common pitfall involves the kidneys. The kidneys are responsible for filtering out and clearing free light chains from the blood. If a patient has impaired renal function, even mild kidney disease, their blood serum levels of kappa light chains will artificially rise because they aren't being filtered out.
Oh, I see. And because the index is a fraction, if the denominator changes, the final number is skewed, potentially giving you a false negative for MS.
Exactly. Another massive red flag is a condition called monoclonal gammopathy, where abnormal proteins are produced in the blood, again throwing off the serum side of the equation. This is the perfect example of Dr. Jones's warning about reductionism.
Right. You can't just trust the machine blindly.
A doctor cannot just look at the 6.1 number and turn their brain off. They have to look at the whole patient, check their kidney function, review their comprehensive metabolic panel, and decide if the math is actually trustworthy. If the patient has kidney issues, the KFLC index is unreliable, and the clinician must fall back on the old-fashioned manual OCB gel test.
So the clinician remains the ultimate safeguard. Okay, so fluid biomarkers like KFLC allow us to substitute chemistry for time. But the 2024 revisions go even further. They introduce a way to use advanced magnetic resonance imaging to substitute for space.
Yes.
If you only have one lesion, you can look deep inside that single lesion to prove the disease. We are talking about the debut of the central vein sign, or CVS, and paramagnetic rim lesions, or PRLs.
These are arguably the most visually fascinating and technologically advanced updates in the entire criteria.
I agree.
To understand what CVS and PRLs are, we have to talk briefly about the physics of how we find them. You cannot see these signs on a standard routine MRI that you might get for a normal headache. They require specific, highly advanced sequences like 3D-T2 echoplanar imaging or susceptibility-weighted imaging.
Susceptibility. We are talking about magnetic susceptibility. We are essentially using the MRI machine as a highly tuned metal detector inside the brain.
That is precisely what it is doing. These specific MRI sequences are exquisitely sensitive to the magnetic properties of different substances in the tissue, specifically iron.
Iron.
Yes, iron is paramagnetic, meaning it distorts the local magnetic field of the MRI scanner in a very specific, measurable way. This allows us to see microscopic structures that were previously completely invisible.
Okay, let's start with the central vein sign, CVS. What is it and why does it prove MS?
The biology here goes all the way back to 1868, to the godfather of modern neurology, Jean-Martin Charcot. Over a century and a half ago, looking through rudimentary microscopes at autopsy tissue, Charcot noticed a distinct pattern. Multiple sclerosis plaques do not form randomly on the white matter. They characteristically form surrounding a central vein or small venule.
So the inflammation literally hugs the blood vessel.
Because the blood vessel is how the immune system gets in. The rogue T cells and B cells are traveling through the bloodstream. To attack the brain, they have to physically breach the blood-brain barrier. They attach to the endothelial wall of a tiny venule, force their way through the tissue, and explode outward into the surrounding myelin. The demyelinating lesion grows radially from that central point.
So I picture the central vein as the vascular highway that the invading army used to arrive. They exit the highway, pitch their tents, and start burning the forest right there at the exit ramp. So if we look at the burnt forest on an MRI, and we can clearly see the highway running right through the dead center of it, we know exactly who caused the fire and how they got there.
It is a beautiful anatomical signature. With these iron-sensitive susceptibility-weighted MRI sequences, the blood in that tiny central vein, which contains deoxygenated iron-rich hemoglobin, shows up as a distinct, dark, hypointense dot or line running right through the center of the bright white MS lesion.
Incredible.
And because MS forms this way, and most other mimicking diseases do not, the central vein sign is incredibly specific to MS. It's fantastic for differentiating an MS lesion from a generic spot caused by aging or small vessel ischemic disease.
But practically speaking, this sounds like an absolute nightmare for a radiologist.
Oh, it could be.
I mean, if a patient comes in with 40 or 50 distinct lesions scattered across their brain, is the radiologist expected to zoom in on every single one and hunt for a microscopic black dot in the center?
That was the massive hurdle to implementing this in the real world. Early proposals suggested a 40% threshold, meaning the radiologist had to painstakingly analyze every single lesion to prove that at least 40% of them had a central vein. It was far too time-consuming for routine clinical practice. A radiologist reading 30 scans a day cannot spend an hour counting microscopic dots on one patient.
So how did the 2024 committee solve the workflow problem?
they adopted a highly pragmatic, data-driven solution called the Select 6 rule. It simplifies the math entirely. The radiologist scans the brain. If they can quickly, confidently identify just 6 lesions that clearly demonstrate the central vein sign, they stop counting.
Just 6.
Just 6. The test is positive. 6 is the magic number to guarantee high specificity. If the patient has a very mild case and has fewer than 10 total lesions in their brain, the rule is simply a majority. The lesions with a central vein must outnumber the lesions without one.
That is a brilliant translation of complex biology into an actionable clinical tool. Now, what about the other major imaging marker, the paramagnetic rim lesions, or PRLs? If CVS shows us the anatomy of the lesion, what do PRLs show us?
CVS shows us the historical architecture, how the lesion formed. PRLs show us the active, terrifying biology of what the lesion is doing right now. A paramagnetic rim lesion is a chronic active lesion. On these specialized iron-sensitive scans, the bright white lesion is surrounded by a distinct, dark, hypointense ring or rim.
Let's go back to our forest fire analogy. If CVS is the highway, the PRL is the smoldering embers. The initial explosive wildfire that stripped the myelin might be over, but there is this ring of embers that continues to quietly, insidiously burn outward, destroying more tissue day by day.
Exactly.
But why is there a dark ring? What is actually physically there causing the magnetic distortion?
The dark ring is a dense, concentrated accumulation of activated microglia and macrophages. These are the immune system's cleanup crew and frontline soldiers. When the myelin is initially destroyed, these cells rush in to devour the cellular debris. But myelin is very rich in iron. As these macrophages gorge themselves in the destroyed myelin, they become bloated with iron.
They are essentially eating themselves into a toxic state.
Yes, and they get trapped at the expanding edge of the lesion. They sit there laden with iron, trapped in a state of chronic activation, constantly spewing out pro-inflammatory cytokines and toxic reactive oxygen species. They're slowly chewing away at the healthy tissue on the border. Because they are packed with iron, they distort the MRI's magnetic field, creating that dark black rim on the scan.
And the clinical implications of these smoldering rings are devastating, aren't they?
They are the biological drivers of progressive multiple sclerosis. Studies consistently show a direct link between a high burden of paramagnetic rim lesions in a patient's brain and worsening cognitive decline, brain atrophy, and global neurologic disability.
Wow.
Patients with multiple PRLs tend to get sicker, faster, and they don't respond as well to our traditional anti-inflammatory therapies because this smoldering iron fire happens behind the blood-brain barrier.
So let's tie all of this new technology together and extrapolate just how radically the 2024 criteria have changed a patient's journey. Imagine a 25-year-old patient comes to the ER with severe optic neuritis. They've never had a neurological symptom before. We do the MRI, we find the inflamed optic nerve, but the rest of the brain and spinal cord are completely clear of lesions.
Okay.
Under the old rules, we send them home. We tell them they have clinically isolated syndrome, and we wait in agonizing suspense for the other shoe to drop, for the next attack to hit their brain or spine.
But under the 2024 criteria, the timeline collapses. We perform a lumbar puncture and find the KFLC index is elevated to 7.2. We have just mathematically proven dissemination in time without waiting. Then we look closely at that single optic nerve lesion, or perhaps one tiny silent spot we found in the brain, using susceptibility-weighted imaging.
And if we see the signs.
Right, if we see a paramagnetic rim lesion, just one single dark iron ring, or if we find the Select 6 central vein sign, we have proven dissemination in space pathobiologically.
We can look that 25-year-old in the eye, definitively diagnose them with multiple sclerosis on day 1, and immediately start them on a highly effective disease-modifying therapy to suppress the immune system. We prevent the second attack before it ever happens. We save their brain tissue.
It is a monumental triumph of preventative neuroimmunology.
However,
Yeah.
there is a massive, terrifying, however, lurking behind all of this technology.
Absolutely.
As we make these diagnostic criteria more and more sensitive, as we allow doctors to diagnose a lifelong disease faster with fewer symptoms, relying heavily on automated ratios and iron rings, the risk of false positives absolutely skyrockets. If you lower the threshold for diagnosis, you catch more MS, but you also catch diseases that look like MS but require entirely different treatments. We have to dive into the mimics.
This cannot be overstated. The authors of the Continuum issue go to great lengths to emphasize this core tenet. The McDonald criteria are fundamentally designed to identify MS only after other, better explanations have been rigorously excluded.
It's not a shortcut.
The criteria are not a magic algorithm that differentiates MS from other diseases. If a doctor blindly applies these criteria to a patient who actually has a mimic, the math will yield a false positive. MS remains a diagnosis of exclusion. You must do your homework first.
Let's talk about the shapeshifters. The conditions that sound like MS, have symptoms like MS, and even produce MRI brain lesions that look exactly like MS. The sources highlight three massive overlap conditions that neurologists must be vigilant against: MOGAD, NMOSD, and the adult onset leukodystrophies.
Right.
Let's start with the antibody-mediated neuroimmunological mimics, MOGAD and NMOSD.
Both MOGAD, which stands for myelin oligodendrocyte glycoprotein antibody-associated disease, and NMOSD, neuromyelitis optica spectrum disorder, are devastating inflammatory diseases of the central nervous system. They frequently present with severe optic neuritis or massive spinal cord inflammation known as transverse myelitis, mirroring an aggressive MS attack perfectly.
But treating them like MS is a disaster.
It can be catastrophic. Many of the standard disease-modifying therapies we use to successfully treat MS are completely ineffective against MOGAD and NMOSD.
Really?
Even worse, certain MS drugs can actually exacerbate NMOSD, throwing the patient into a severe disabling relapse. You have to tell them apart before you treat.
So how does a clinician use these new advanced imaging techniques to differentiate them? Let's look at the optic nerve. How does optic neuritis in MOGAD differ from MSRI?
It comes down to the precise anatomy of the attack. MOGAD is a glycoprotein located on the outermost surface of the myelin sheath. When MOG antibodies attack, the inflammation is explosive. In typical MS, optic neuritis usually affects only one eye, and the lesion is short, covering less than 50% of the nerve's length.
But in MOGAD?
In MOGAD, the attack is frequently bilateral. It strikes both eyes simultaneously. It extensively involves the anterior portion of the nerve, often inflaming more than half of its total length.
And the MRI shows a very specific visual signature for MOGAD, right? The tram track appearance.
Yes, because MOGAD causes profound inflammation, not just of the nerve itself, but of the optic nerve sheath and the perioptic fat surrounding the nerve. When the radiologist injects gadolinium contrast dye, that surrounding inflamed sheath lights up brightly on the scan.
Like a halo.
Exactly. If you look at it in a coronal cross-section, the inflamed sheath surrounding the dark nerve looks like a bright donut. If you look at it longitudinally, from the side, the two bright inflamed edges run parallel to each other, looking exactly like train tracks or a tram track. If you see the tram track, you should immediately test for MOG antibodies, not diagnose MS.
And what about NMOSD? What is its unique signature?
NMOSD is driven by antibodies against aquaporin 4, which is a water channel protein primarily located on astrocytes, another type of support cell in the brain. NMOSD also causes severe, often bilateral optic neuritis, but its anatomical predilection is different. It loves the posterior optic pathways. It very characteristically attacks the optic chiasm.
The chiasm is that tiny, delicate X-shaped structure deep inside the brain where the optic nerves from the left and right eyes cross over and merge before heading to the visual cortex.
Exactly. If you see an isolated glowing lesion sitting right dead center on the optic chiasm, that is a glaring red flag for NMOSD. MS rarely isolates the chiasm in that specific way.
The anatomy of the attack reveals the identity of the attacker. That makes sense for the inflammatory mimics. But the category of mimics that truly blew my mind in this continuum issue, the ones that result in the most tragic clinical outcomes, are the adult onset leukodystrophies.
Oh, absolutely heartbreaking.
Because historically, when a medical student hears the word leukodystrophy, they immediately think of heartbreaking pediatric genetics. We think of infants or toddlers losing their motor skills. We don't think of a 45-year-old walking into an outpatient neurology clinic complaining of a stiff leg.
And that deeply ingrained medical bias is exactly why these adult patients are so frequently and tragically misdiagnosed with MS. Leukodystrophies are rare genetic disorders that intrinsically disrupt the growth or maintenance of the brain's white matter. Thanks to the rapid implementation of next-generation genetic sequencing, the medical community is suddenly discovering that many of these genetic disorders have adult-onset phenotypes that are much milder, slower, and more insidious than the fatal pediatric versions.
And they masquerade perfectly as primary progressive multiple sclerosis.
Almost flawlessly. Take genetic diseases like ALSP or Ketocell. A patient in their 40s will present with slowly progressive spasticity, a severe muscle stiffness and weakness in their legs. They might develop ataxia, becoming uncoordinated and stumbling. They might show early signs of cognitive decline or personality changes.
And then they get scanned.
Right, and when the neurologist orders an MRI, the scan reveals multifocal confluent white matter lesions scattered throughout the brain.
The doctor sees the progressive leg weakness, sees the white matter spots, applies the McDonald criteria, and concludes they have met dissemination in space for MS.
It is a devastatingly easy trap to fall into. The Continuum text cites a retrospective cohort study of patients with adult-onset leukodystrophies who were initially misdiagnosed with MS. The statistics are staggering. The mean diagnostic delay was 9 years.
9 years?
9 entire years of living with the wrong disease label. And for some unlucky patients, they carried the false MS diagnosis for 20 to 25 years before someone finally ordered a genetic panel.
Let's talk about the real world harm of that misdiagnosis. It is not just the psychological burden of being told you have an autoimmune disease when you actually have a genetic mutation. There is profound iatrogenic physical harm caused by the medical system itself.
The harm is quantifiable and severe. The data show that nearly half of those misdiagnosed patients were unnecessarily given massive doses of intravenous steroids to treat what the doctors thought were acute MS relapses. Steroids have massive side effects: bone density loss, severe mood swings, blood sugar spikes, immune suppression.
And a quarter of those patients were put on long-term MS-specific disease-modifying therapies. These are heavy-duty immunosuppressants,
Which are completely biologically useless for a genetic structural condition. You are carpet bombing the patient's immune system, exposing them to potentially lethal opportunistic infections for disease they do not have.
That's just tragic.
Furthermore, by missing the genetic diagnosis, the clinician deprives the patient of vital genetic counseling. These patients might have children or siblings who carry the same gene, completely unaware. And finally, they miss out on the newly emerging, highly targeted genetic therapies or bone marrow transplants specific to leukodystrophies.
The sources mention one specific genetic condition that highlights just how deceptive these mimics can be: vanishing white matter disease. How does a genetic mutation trick a doctor into seeing an immune relapse?
Vanishing white matter disease is caused by mutations in the EIF2B genes, which regulate cellular stress responses. In the adult onset form, a patient might have the underlying genetic defect, but remain entirely asymptomatic for decades. But the disease process can be suddenly, violently triggered by acute physiological stress.
Give me an example of physiological stress.
A severe viral infection with a high fever, a mild head trauma, an extreme summer heat wave, or the massive hormonal and physical shifts of pregnancy and childbirth. The stressor overwhelms the defective cells. They undergo rapid apoptosis, cell death, and the patient suffers a sudden, abrupt neurological deterioration.
So a 30-year-old woman gets pregnant, delivers a healthy baby, and 3 weeks later suddenly loses the ability to walk. The doctor does an MRI and sees massive new white matter destruction. Any standard neurologist would instantly think, this is a classic postpartum MS relapse.
Precisely. Which is why the 2024 criteria practically screened the clinician to actively hunt for radiologic red flags before giving the MS diagnosis. You must look closely at the MRI. Does the scan show persistent restricted diffusion, which implies a different type of cellular swelling? Are there tiny calcium deposits or calcifications in the brain?
Right, because MS doesn't typically calcify.
Exactly. Is there symmetrical involvement of the anterior temporal poles, which is classic for CADASIL? Most importantly, does the patient lack oligoclonal bands or an elevated KFLC index in their spinal fluid? If the CSF is normal, but the MRI looks like a war zone, the clinician must hit the brakes, step back, and order a genetic panel.
You cannot let the sensitivity of the new MS rules blind you to the genetics. This need for extreme caution extends heavily to specific patient populations where the traditional rules of MS diagnosis simply behave differently. Let's look at how the 2024 criteria adapt strictly based on age and demographics, starting with the youngest patients, pediatrics.
Diagnosing pediatric onset MS requires intense, specialized scrutiny because kids' immune systems are incredibly volatile. The primary non-negotiable caveat in the 2024 criteria is that you absolutely cannot apply the MS diagnostic criteria at the time of an ADEM presentation.
What is ADEM?
ADEM stands for acute disseminated encephalomyelitis. It is a sudden, explosive, widespread attack of inflammation in the brain and spinal cord. It very frequently occurs in children shortly after a routine viral infection or, much more rarely, a vaccination. The child presents with multifocal neurological deficits and, crucially, encephalopathy, meaning severe confusion, extreme lethargy, or even falling into a coma.
If you scan that child's brain, it is lit up with massive inflammatory lesions. It looks like the most aggressive first attack of MS imaginable.
It does, but historically, ADEM was considered a monophasic illness. meaning it happens once, the child recovers, and it never happens again. It's not a chronic progressive disease like MS grip. However, the medical landscape has changed recently. We now know through advanced antibody testing that approximately half of all EDEM presentations in young children are actually driven by MOGAD, that mimic we discussed earlier.
So MOGAD is hiding inside the ADEM presentation.
Exactly. Therefore, the new criteria mandate that for any child under the age of 12 presenting with an acute central nervous system demyelinating event, you must perform MOGAD antibody testing. It is virtually mandatory. You have to rule out MOGAD before you can even begin to think about an MS diagnosis. And even if the MOG test is negative, you cannot diagnose MS during the acute ADEM phase.
You just have to wait.
You have to wait for the storm to pass, let the brain cool down for at least 90 days, and see if a second distinct non-ADEM attack happens in the future.
You have to protect the child from a lifelong diagnosis based on a one-time viral overreaction. Okay, so that's the extreme caution required for pediatrics. Let's look at the complete opposite end of the spectrum. Late onset patients, meaning people experiencing their very first potential MS symptom over the age of 50. What is the danger here?
The danger with patients over 50 is that the brain MRI itself becomes an incredibly noisy, unreliable diagnostic environment. As human beings age, it is incredibly common, almost expected, to develop small, non-specific white matter lesions in the brain. These are typically the result of accumulated vascular risk factors over decades of life. High blood pressure, high cholesterol, a history of migraines, smoking, or just general microvascular ischemic disease.
The brain essentially accumulates a few dents and scratches just from the wear and tear of living.
Right, we call it leukorrhiosis. So imagine a 55-year-old patient with a 20-year history of hypertension and severe migraines comes into the clinic complaining of dizziness, a very vague, non-specific symptom. The doctor orders an MRI and sees multiple white spots in the paraventricular area.
If that doctor blindly applies the standard McDonald criteria, they will count those vascular spots as MS lesions, tick the box for dissemination in space, and deliver a false positive MS diagnosis to a patient who just has age-related blood vessel wear.
Exactly. To prevent this, the 2024 criteria demand a significantly higher burden of proof in the over 50 population. The standard MRI rules are not enough. The clinician must seek additional, highly specific proof that those spots are actually immune-driven demyelination and not just vascular noise.
How do they prove that?
They need to find lesions in areas that are rarely affected by vascular disease. For example, they need to scan the spinal cord. Age-related vascular spots almost never show up in the cervical cord. If the cord is clean, they need positive CSF biomarkers. They must do the lumbar puncture and find that KFLC index of 6.1 or the oligoclonal bands to prove an active immune response. Alternatively, they can use the advanced imaging we discussed. They must demonstrate the Select 6 central vein sign.
Oh, because the central vein proves it's immune, not vascular.
If they can show the veins inside those spots, they can confidently say it's MS. If they can't meet these higher burdens, they cannot diagnose MS.
It is all about dynamically raising the burden of proof when the diagnostic waters get murky. But if we are talking about murky waters, we have to talk about the absolute deepest, most profound conceptual shift in the entire 2024 criteria update. This is the concept that honestly kept me up at night after reading the sources. We hinted at it in the very beginning. We need to talk about radiologically isolated syndrome, or RIS.
RIS is the absolute frontier of modern neurology. It represents the ultimate collision of advanced diagnostic technology and medical ethics.
Let's define it clearly. RIS occurs when a patient gets an MRI for a completely unrelated reason, a concussion, a headache, participating in a healthy volunteer research study, and the scan accidentally reveals classic ovoid demyelinating lesions in the brain that look exactly like multiple sclerosis. But the patient has never, ever experienced a single neurological symptom in their entire life. They have no clinical history of the disease. They feel perfectly 100% healthy.
Historically, if a neurologist found these silent spots, their hands were tied. MS was defined as a clinical disease. If there are no clinical symptoms, there is no disease. The doctor would sit down with this perfectly healthy person and have an incredibly uncomfortable conversation. We found some spots on your brain. They look like MS, but you don't have MS. We are just going to watch and wait. Go home and call me if you go blind or your legs stop working.
Living with a ticking time bomb in your head, waiting for it to go off. But the 2024 criteria obliterate that old paradigm. The new rules state unequivocally that MS can be officially diagnosed in a patient with RIS without that patient ever experiencing a single clinical symptom.
That is the monumental shift. If that completely asymptomatic patient meets the MRI criteria for dissemination in space, and they also possess highly specific pathobiological biomarkers, if we find the select 6 central vein sign, or if we do a spinal tap and find a positive KFLC index, or if we follow them with MRIs and see new silent lesions forming over time, proving radiologic dissemination in time, we can officially diagnose them with multiple sclerosis.
Let's just pause and extrapolate the sheer weight of that action. You are diagnosing a patient with a chronic, incurable, potentially disabling neurological autoimmune disease when they feel absolutely perfectly healthy. The psychological impact of that conversation in the doctor's office must be earth-shattering for the patient. Why on earth would the medical community agree to do this? Why label someone as sick when they feel fine?
We do it because the data demands it, and because our biological understanding of the disease has evolved. The longitudinal statistics on RIS are terrifying. The sources show that 51.2% of adult patients with RIS evolved to have their first clinical symptom within 10 years. In the pediatric RIS population, it's even faster and more aggressive. 42% suffer a clinical attack within a median of just 2 years.
More than half will develop the clinical disease within a decade.
Yes, and fundamentally, we now know that these silent lesions are not benign. They are biologically identical to MS GRAD. The central veins are there, the macrophages are there, the immune fire is burning, actively destroying central nervous system reserve, even if the fire hasn't reached a critical motor or visual pathway yet. By diagnosing them at the RIS stage, we unlock the ability to intervene. We can offer this asymptomatic patient highly effective disease-modifying therapies before the first irreversible clinical injury ever occurs.
We are attempting to stop the first attack before the patient ever feels it. We are trying to preserve 100% of their functional brain tissue, but still treating a completely asymptomatic person with heavy-duty, expensive immunosuppressants that carry risks of liver damage, severe infections, and fatigue. It is an ethical and clinical tightrope of the highest order.
It is the ultimate tightrope. And it brings us full circle to the core philosophy expressed by Dr. Jones in his editorial. With RIS, we aren't just treating a static scan. We're utilizing advanced molecular and radiologic biology to predict and fundamentally alter a human being's future trajectory. But it requires an incredibly skilled, empathetic clinician to weigh the risks of the medication against the predictive certainty of the biomarkers and to navigate a deeply nuanced, shared decision-making conversation with the patient.
Which perfectly sets up our summary of this incredibly dense, fascinating deep dive. We have covered an astounding journey today. We have watched the diagnosis of multiple sclerosis evolve from a crude, frustrating clinical exercise waiting in the dark for a patient to suffer multiple devastating attacks to a highly precise pathobiological matrix.
We have mapped out a new geographic territory, utilizing the optic nerve and microscopic retinal measurement as a fifth dimension of space. We've explored how automated fluid biomarkers like the kappa-free light chain index can objectively measure the immune fire and substitute for the agonizing weight of time.
Right.
And we have seen how advanced magnetic susceptibility imaging allows us to peer into the active biology of the disease, finding the vascular highways of the central vein sign and the smoldering iron embers of the paramagnetic rim lesions.
But through all of this staggering technological advancement, through all the talk of automated ratios and iron deposits, the overarching message of this continuum issue is one of profound respect for the human element of medicine. The technology does not replace the doctor. It amplifies the doctor's responsibility. To reiterate Dr. Lyle K. Jones Jr.'s foundational point, neurology will continue to become more molecular, but it will not become less neurologic.
The clinician is not being replaced by algorithms or automated lab machines. On the contrary, the clinician is the crucial, ultimate arbiter. They're the only ones capable of contextualizing these incredibly sensitive, sometimes entirely silent biomarkers against the patient's lived reality, their age, their medical history, and the ever-present danger of genetic and inflammatory mimics.
It's a beautiful, challenging way to look at the future of medicine. The tools are sharper, but the hand wielding them must be steadier than ever. Before we go, I want to leave you, our listener, with a final provocative thought to mull over. It builds directly on the ethical paradox we just discussed with radiologically isolated syndrome. If we can now definitively diagnose a complex disease like multiple sclerosis using iron-sensitive MRIs and protein ratios in a patient who has never experienced a single neurologic symptom, Are we fundamentally redefining what it means to be sick?
It's a heavy thought.
In the future, as our technology becomes ever more microscopic, will diseases be defined not by the tangible suffering they cause in our daily lives, but entirely by the silent molecular fingerprints they leave behind in our biology?
It is a profound question about the evolving boundaries of human health, disease, and our ability to predict the future.
It really is, and it's a question we will all have to face as medicine marches forward. Thank you for joining us on this highly clinical, deeply fascinating deep dive today. Keep questioning the science, keep looking for the invisible connections, and we'll catch you on the next deep dive.